Hi guys, what I thought I'd do is go over these Core 1 sections in critical questions just to make the videos a little bit smaller to upload easier, as well as making them just short snippets of information for you to follow. Just a reminder, this is not to reteach the information or to teach it for the first time. It should just be rehashing the information that we've already gone over, trying to get you to recall some of that short-term memory. So I'm going to have a look at Core 1 in Health Priorities in Australia, and that has two parts of critical question 1. 1A is measuring health status, so looking at epidemiology, who uses it, how is it gathered, and of course what are the limitations of epidemiology. And critical question 1B is health priorities, prioritising health issues, so how do they identify and prioritise, and what are the national health priority issues. So things we need to remember is epidemiology is a mathematical science. Okay, it is a quantitative data set, so it is very objective. Therefore, it can tell us who uses medical services, what sort of diseases are being diagnosed, what sort of medications are being prescribed or taken. But it is very limited in the fact that it is quantitative. So therefore, it can't tell us everything about a disease. It can't tell us somebody's quality of life. It can't tell us the determinants that contributed. It certainly can't tell us the reasons behind the risk or protective factors that somebody employed throughout their lifetime to get to that. But it is very good at measuring how sick a nation is, what are the disabilities, and of course, where is the funding being put to counteract those diseases and illnesses within a community. There's a whole range of different agencies that use epidemiology. The Australian Bureau of Statistics, most importantly the Australian Institute of Health and Welfare, where we get most of our data from. Non-government organisations such as Cancer Council, National Heart Foundation, Kidney Association, they all gather the data, okay, and they get it from our hospital admissions, our GP admissions, our prescriptions, our PBS, how many antidepressants are being prescribed each year, and that all is collated and is utilised by epidemiologists to study disease. So epidemiology is the study of the frequency of a disease within a population and the attempt to identify the causes and distribution of those diseases. So I'll just read that out again. It's really important that you be able to write that down. So epidemiology is the study of the frequency of a disease within a population and the attempt to identify the causes and distribution of those diseases. And it does so in 4 ways. So it measures mortality, morbidity, infant mortality, and life expectancy. As you know, mortality is the number of deaths for a given cause in a given population over a set period of time. Okay, so it's a number of deaths of a given cause in a given population over a set period of time. So it could be the number of deaths from cardiovascular disease since 1944. It could be the number of deaths from cardiovascular disease between 2012 and 2014 for males. It can actually identify very specific groups, or it can be very broad. Morbidity is divided into 2. So morbidity is the study of disability and illness. However, that is divided into prevalence. So it's the occurrence of the disease in a given population, whereas incidence is the occurrence of the disease in a given population for a specific time period. So with incidence, we're looking at, from 2012 to 2018, this many people suffered cardiovascular disease, whereas prevalence is just, 25% of males suffer from cardiovascular disease. It doesn't actually give a specific time period. Right, so incidence is over time, prevalence is just the occurrence in a population. Infant mortality is the rate of deaths in the first year of life per 1,000 live births. Okay, our infant mortality directly affects our life expectancy rate. And if we just go back to mortality, our overall trend is going down. For morbidity, our overall trend is remaining pretty stable. So some things are going up, some things are going down. So cardiovascular disease is actually going down. However, diabetes is actually going up. Right? Infant mortality, our rate is declining, okay, through better emerging technologies, our better medicines, our better knowledge of prenatal care. There's a whole range of different determinants there. But again, that's not quantitative data, that's only qualitative. And then life expectancy. So life expectancy is the estimated number of years a person can expect to live. And we are quite high in the nation, so I think we're sixth for both males and females, and that is continuing to rise. So we're approximately around about, if you were to write the average ages, life expectancy is around 80 to 82. Okay, you'd be correct. So it's right on 80 for males and 84 for females. So just make sure you put the females as 4 in front. So where does epidemiology come from? Where do we actually get it? So our Medicare card is probably the largest place that epidemiological data comes from. So when you go to a Medicare centre, you swipe it. When you go to a chemist, you swipe it. When you go to a hospital, it's used. And it's not so much to track you as an individual. It is just basically tracking all the medical conditions that go along with you. Hospitals also use that information. You'll notice when you first present at an emergency ward or emergency room, you'll be asked for your Medicare card, and then that just tracks what was diagnosed, what care was provided, how long your stay was for. Same thing with GPs. When you go to a GP, whether you bulk bill or not, they still take your Medicare card, and any prescriptions or diagnosis attached to your number is recorded. And through this census, every 5 years, the Australian Bureau of Statistics also cover that information. So there's a whole range of institutional and non-institutional departments that actually use your epidemiology. What can it measure? Well, it can obviously measure the number of deaths, illnesses and injuries in a population. It's very good at identifying affected groups, so it can hone into priority population groups. Also, males versus females, young versus old, specific age groups, those sorts of things. It can identify trends in death and disease. So is something going up? Is something stable? Is something going down? And then obviously they link that to what's being done by the government and individuals. What sort of medical services are being used? Who are using those medical services and where are they being used? That can be very powerful for the government to decide where to put a new hospital or relocate a hospital. And a good example of that is that breast screening van down in East Maitland near Henny Penny is actually one of the most used in the state, and so they're talking about funding another one because obviously there's a high volume of people needing that service here in the Hunter, so they're going to put another one out at Rutherford area. It can't obviously measure the quality of life. It can't, if someone dies from a car accident at the age of 42, it can't measure how good of a life or whether they had lots of people who loved them or didn't love them. It can't tell you if they were happy or suffered from mental illnesses, or those sorts of things. It certainly can't track the contribution of health determinants. So social cultural, if you die of cardiovascular disease, there's not an opportunity to say, well, my parents fed me really high fatty food when I was young, or my parents were smokers inside, so I had a lot of passive smoke, which contributed to my lung cancer, which is why I smoked and why I died. So there's all those sorts of different things that it cannot tell. It can't tell you about holistic life, so that's your life as a whole. So your risk factors, your protective factors, it can't say whether or not you ate a healthy diet, very strict for your entire life, and you're just unlucky to suffer from cancer. Okay, so it can tell a lot about things. Remember, it's just quantitative, it is not qualitative. You don't need to know the actual statistics, okay, but you do need to know whether trends are going up or down or remain stable, okay, and there are sometimes questions about the differences between males and females, so just be prepared for that. We did a few different activities there. I'm just not going to fly over those. And that's it for critical question 1.